For our project, we were interested in how can we improve risk stratification for a patient that's newly diagnosed with AL amyloidosis. AL amyloidosis is caused by light chains, which are proteins that are produced by plasma cell clones. And these light chains can get all around the body, from the heart, the kidney, nearly every organ except the central nervous system. And that can cause heterogeneity in this disease. So we have risk stratification tools that clinicians use when a patient is newly diagnosed that looks at, what's the organ involvement for the disease. But some limitations that we currently have is that staging systems only use a handful of biomarkers when we know that there are many biomarkers in addition to those that can predict outcomes. The second thing is that we have multiple outcomes we're interested in. These patients might be, at early risk of death, but they also might be at risk of progressing to end-stage renal disease. And so we care about many different things. So for our work at the Boston University Medical Center, we're fortunate enough to work with many patients and have a large cohort, and wanted to use unsupervised machine learning techniques to take all of these patients that we have, along with a comprehensive set of biomarkers, and use those together to come up with novel subgroups that could help us prognosticate for outcomes of interest. So what we found was that we identified 3 novel subgroups that we term low, intermediate, and high risk based on their median overall survival from diagnosis. And interestingly, we found that the intermediate subgroup had a high propensity for renal involvement. We found a lot of renal markers, such as low estimated glomerular filtration rate, low serum albumin, high amounts of proteinuria. And our high risk was actually consistent with current staging systems and had high cardiac involvement. So interestingly, just looking at the clinical characteristics, we found that we had this renal phenotype as well as this cardiac phenotype. When we looked at our outcomes, we found that we were actually able to prognosticate for both all-cause mortality as well as end-stage renal disease. And we found that whenever we tried modeling existing staging systems along with existing biomarkers that are used, our subgroups are still providing some interesting information as well, and predicting for both. Finally, how do we use this in the clinic? That's kind of the question that we wanted to know. And that comes with how do we assign newly unseen patients to our existing subgroups? And to do that, we also developed machine learning classifiers that take a subset of those biomarkers, easily ones that you can get in the clinic, and then predict those for unseen patients.